You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Hello, everybody, and welcome yet to another episode of the Nailed It Ortho Podcast. You're actually tuned into our Citation Classics, the very first one on sports, which I'm actually going into sports, so shout out to sports. Our very first Citation Classics on sports. I'm really looking forward to this. We have a cool team of people, and this will be our first Sports Citation Classics episode, and we hope to do many more in the future. But let me just go ahead and introduce some of the people that are a part of this squad that will talk some sports. And today we'll talk a little about ACL reconstructions. But the main man, the person in charge here is Dr. Tucker Peabody, PGY1 resident at Ohio Health Doctor Hospital. We also have Dr. Ehab Nazzal, a PGY2 resident at the University of Pittsburgh. We have Tyler Thorne, who is a fourth-year student at the John A. Burns School of Medicine. Then we also have Tariq, who is actually in the combined bachelor's MD program in Missouri, currently in his 5th out of 6th year. So hopefully today we get into some good ACL, and I'm just going to go ahead and let Dr. Tucker Peabody here. Tucker, I'll let you go ahead and take the reins and let us talk some more ACL, some more citation classics, and we'll go from there.
All right, good deal. Well, first off, thanks for having me. It's very fortunate to be a part of this. And, like I told you before, I've been listening to you guys for, well over a year now when I was a 3rd, 4th year medical student. So it's good to be on the other side of things. But let's get started. So the topic we're starting off in our sports section is specifically ACL reconstruction. And there's a lot of literature out there regarding ACL reconstruction, different types of grafts, techniques. I thought it was a very good topic to start off with. So we got about 5 papers here that we'll talk about regarding ACL reconstruction. And we're going to start it off with this prospective randomized trial comparing single bundle versus double bundle. And Ehab, why don't you go ahead and take over?
Awesome. Appreciate it. Yeah, just to echo, thank you so much for having me here. I really appreciate it. So I'll be talking about this study, which is a prospective randomized clinical evaluation looking at conventional single bundle, anatomic single bundle, and anatomic double bundle ACL reconstruction. I think it's fitting that I'm talking about this since the PI on this paper was Dr. Fu. As you all know, Dr. Fu is a powerhouse in the sports medicine department at the University of Pittsburgh, as well as internationally for decades. So to be able to talk about this article and, in the function of being one of his students, I really did see him as a mentor. I really do appreciate the opportunity.
Yeah, Dr. Fu was great.
Yeah. So just as a background, so looking at conventional or a transtibial ACL reconstruction, so we know that this restores anterior tibial translation, but there's a question of whether it really restores rotatory stability. We learn in medical school, the function of ACL is anterior posterior stability, especially with the anterior drawer that we all learn about. But it's not really until we get into residency that we start talking about the rotatory stability, especially with the pivot shift. So previous biomechanical studies have showed the anatomic double bundle ACL reconstruction restores knee stability closer to normal than just a conventional or transtibial single bundle ACL reconstruction. The issue with that, though, is that there's a lot of conflicting literature, and it really stems from really a lack of specifying whether reconstruction techniques are transtibial or anatomic in papers. We know that failing to really identify these techniques introduces confounding results, which not only influences outcomes, but more also influences range of motion, knee kinematics, potential threats to the graft, and eventually graft failure. So on the figure on the right, I just kind of pulled from another paper that you can see just the differences between both the single bundle and the double bundle. So the purpose of this paper was to compare the results of 3 different techniques of ACL reconstruction. It was to determine if the double bundle ACL reconstruction is needed to restore rotational stability, or if you could just get away with an anatomic placement of a single bundle ACL reconstruction to yield similar results. The hypothesis, there were two of them. Anatomic single bundle ACL reconstruction is superior to conventional single bundle ACL reconstruction, and anatomic double bundle ACL reconstruction is superior to both conventional and anatomic single bundle ACL reconstruction. terms of the method, so this was a prospective randomized clinical study. So level 1, there were 3 groups, the conventional single bundle, the anatomic single bundle, and the anatomic double bundle. And in terms of inclusion criteria, they were really looking at ACL ruptures in active patients, and then also looking for patients with closed growth plates. Exclusion criteria, so really just dealing with isolated injuries, no multiligamentous injuries here. Excluded patients who had bad osteoarthritis of the knee, any sort of previous meniscectomy, and then they wanted to be able to compare to the contralateral side, so no contralateral ACL deficient knees, and then they wanted complete ruptures. In terms of measured outcomes, they looked at anterior tibial translation with the KT1000 machine, and they did a side-side difference to the contralateral side. They did a pivot shift to test the rotational stability, specifically an internal rotation in valgus. They looked at knee range of motion. And in terms of patient-reported outcomes, they did the LISM score, and then they did subjective and objective IKDCs. In terms of results, so there are a lot of charts here, but we'll kind of go over just the main results here. So in comparing conventional single bundle and anatomic single bundle, in terms of AP and rotational stability, they found that the anatomic single bundle was superior to the conventional single bundle, but there was no difference in the LISM or the subjective IKDC scores. In terms of conventional single bundle and comparing that to the anatomic double bundle, the anatomic double bundle was superior to the conventional single bundle for all measured outcomes, except for a subjective IKDC score. And then looking at the anatomic single bundle versus the anatomic double bundle, the double bundle was superior to the single bundle for AP, rotational stability, and knee range of motion, but there were no differences between groups for LISM score or subjective or objective IKDCs. So overall, the anatomic double bundle was found to be superior to both the conventional single bundle and the anatomic single bundle. And also the anatomic single bundle was found to be superior to conventional single bundle. So kind of the most important thing here is it really implies the most important factor of ACL reconstruction, which is anatomic reconstruction. So in the early 2000s, looking at single bundle and double bundle, there was really a lot of hype about should we be doing single bundle or double bundle for each patient? Like, should we actually try to truly replicate the 2 bundles? And ultimately, it kind of fizzled out just from a biomechanics and an outcome standpoint. The training that was required to do a double bundle, as well as the increased operative time, didn't really measure up to just doing a single bundle. However, this study really does show the importance of an anatomic reconstruction. So looking at your MRI and understanding where your tibial insertion point is, where your femoral insertion point is, and trying to recreate that as well as possible. In terms of limitations to the study, though, so again, there was no individualization of surgery. So we weren't doing a select graft type or size. We weren't looking at like really insertional site morphology. So you couldn't really individualize that due to randomization of the study, which kind of explains why that limitation exists. In terms of future studies, though, repeat comparisons looking at more individualization in order to more accurately perform tunnel placement, again, to really make the procedure more anatomic. And I think the goal here is how anatomic can you make this? Like, how individualized to each patient can you make this ACL reconstruction? And it's something that I know personally, Dr. Van Eck and Dr. Fu, especially Dr. Fu, really stressed. And it's something that we're really trying to get to in terms of ACL reconstruction, especially at the University of Pittsburgh.
Yeah, I think it was a good paper. And, one of those points that you touched on is that, outcomes were pretty much the same. But again, one of the big things is like, the double bundle, you have increased operative time. There's a different level of technical skill needed for that too. But yeah, I think that was great.
All right. Yeah, it was a really good paper. I'm, interested in sports, and, I'm only a PGY1, and I get to see, any double bundle reconstructive procedures. Yeah, I feel like I haven't really heard it discussed much. So it'd be interesting to hear what you guys, if you've seen any, and, pros and cons.
Yeah, I haven't seen any in my residency. They're all been single bundle. What about you? You've seen some double bundles over there?
No, it's kind of fallen to the wayside. We do it in the lab. So I'm in the research year actually at UPMC, the 6-year program. So I work in the sports lab. So sometimes we do still do the double bundle just for like a few side projects that are going on, but I've never seen it clinically done. And the reason why is I really do think that people have kind of subscribed to the idea that they would rather really understand the insertion site and go for as anatomic as possible with a single bundle rather than cutting your graft or having to prepare your graft differently. It just, I think, isn't worth the extra time for the outcomes, as well as the increased operative time. So I haven't seen any personally.
Awesome.
Yeah. Okay.
All right. Well, let's keep this trend going. We'll continue with the next paper presented by Thorne, talking about risk of secondary injuries in these younger athletes after they have an ACL reconstruction.
All right. Yeah. Thanks for having me. I love the show, so excited to contribute. So this is a systematic review where they looked at the risk of secondary injury in younger athletes after ACL ligament reconstruction. So just moving on to the background, ACL is the most commonly injured ligament in the knee, and there's roughly 100,000 to 200,000 ACL reconstructions a year. But following ACL reconstruction, injury to the ipsilateral or contralateral ACL is a disastrous but known outcome. And across the literature, graft failure rates range from 3% to 25%. And there are many known factors that are associated with good outcomes after ACL reconstruction, such as surgical technique, graft choice, rehabilitation, and patient education. But despite all of this and the high occurrence rates, risk factors for graft failure and contralateral ACL rupture are not really clear. So the purpose of this meta-analysis was to assess the risk factors of age and activity level after ACL reconstruction in secondary ACL injury. And they hypothesized that young age and return to sport would increase secondary ACL injury risk. Moving on to the methods, they did this meta-analysis through searches of PubMed and EBSCOhost. They have a little flow chart there that shows how they decided on their studies. And they searched terms related to the field, such as ACL, reconstruction, return to sport, age, risk factors. And they included level of evidence range from 2 to 4. There was no level 1, as there's been no randomized controlled trials. And the factors that they looked at were number of patients, demographic, outcome measures of surgery or injury of ACL, re-injury rates for the ipsilateral side, contralateral side, and total re-injury rates. So moving on to results, through the meta-analysis, they found that ipsilateral re-injury rate was 7% and a contralateral injury rate of 8%. Although from the individual studies, there was a large range from about 4.7% to 20.5%. And then collectively, the total secondary ACL injury rate was 15%. Patients under the age of 25 had a secondary ACL injury rate of 21%, and that's including both ipsilateral and contralateral. Secondary ACL injury rate for athletes returning to sport was 20%. And then combining those two risk factors, secondary ACL injury rate for athletes younger than 25 years old who returned to sport was 23%. Thus, younger age and returning to sport increased the percentage of secondary injury from 15% in the general population to 23%. So the big takeaways and conclusions from this is that younger aged athletes under the age of 25 who return to sport are associated with a higher risk of secondary ACL injury. And from this study, they just showed that nearly 1 in 4 athletes returning to play will have a secondary ACL injury. And then those athletes returning to sport are at actually 30 to 40 times greater risk of ACL re-injury compared to their uninjured counterparts. And also an interesting fact of this is that contralateral limb injury exceeded rates of ipsilateral graft rupture after the primary ACL surgery. And this held regardless of controlling for age or activity level. The limitations of this study include inadequate reporting of secondary ACL injuries, So several studies only reported ACL revision surgery. So this might have missed patients and athletes who had injury but did not undergo a secondary procedure. The lack of standardized information about patient follow-ups, rehab status, graft size type, and surgical technique. So there's some future directions from this work. So despite all of the rehab protocols we have, there is still a significant risk of re-injury. So further investigation is needed to evaluate rehab protocols and their guidelines.
Yeah, I really enjoy this paper, and I think it's something that we needed to discuss more about, especially with these younger athletes and their increased risk of injury, especially any athlete can attest to wanting to get back onto the field or the court as early as possible after an injury. And it's tough to discern whether or not these athletes, regardless of what level they are, their rehab protocols, because that can be just as important as the surgery itself. And if the surgery can go great and you can have an excellent graft take, but if you're rushing your rehab, you're kind of putting yourself at risk for an injury like this paper showed. So I think, further research for, standardized like therapy protocols and time of these rehab therapies, would be pretty beneficial.
I also think this is an important paper because, as we kind of move into the future with ACL reconstruction, a lot of, sports surgeons or people doing these procedures are guaranteeing quicker return times, like really trying to push the envelope in terms of how quick can I get you back on the field. And I think that, for the patients, and especially those who want to be back as quickly as possible, that's a really attractive option. And it's potentially easy to talk to parents and children and say, hey, I can get you back in 6 months. I can get you back in 7 months. But I mean, this data is just so important to show that, A, people who are going back super quickly are going to be at risk without a good therapy protocol. And B, these younger age kids are at an even higher risk. So it really does bring to light an important point. So I'm glad we talked about it.
Yeah, good article.
Yeah. One more quick thing, just kind of going over ipsilateral versus contralateral injuries. I think it needs to, be discussed, especially with these rehab protocols. Are they taking into account the contralateral limb? Because obviously there's going to be different loading, different biomechanics, because you're compensating for so many months. What long-term effects does that have? So, I mean, I don't know the specific rehab protocols, but I'd be curious to see, what they do for the healthy limb.
Yeah, and then there's a lot that goes in the ACLs, and even like preventing ACL injuries from happening, and neuromuscular training. I mean, there's a lot of research in the ACL in general, and trying to prevent injuries versus, again, having a secondary injury after you have an ACL injury. But yeah, I think it's a pretty good paper here.
Yeah. All right, let's keep it going. All right.
Yeah, so this is a meta-analysis titled "Outcomes of Single Bundle versus Double Bundle Reconstruction of the ACL," and this is a study, again, a meta-analysis that was done out of the Tau Orthopaedic Institute in New Mexico, and some Smith and Nephew stuff in Massachusetts. So just to give a little bit of background, I mean, Ehab kind of described it a little bit earlier, but again, we have our two bundles of our ACL. You have the anterior medial and posterior lateral bundle. And the anterior medial bundle is supposed to provide some restraint against anterior and posterior tibial translation. The posterior lateral bundle is supposed to help with some of the rotary instability. And so when we talk about, ACL reconstructions, you have a single bundle technique where you just, that one graft serves as both bundles, and you have a double bundle technique where you try to recreate the normal anatomy of the ACL, and you try to make a posterior lateral and an anterior medial bundle. And so one of the hypotheses of using a double bundle technique was that you can get failure after single bundle due to minimal internal rotation and valgus control, which again, Ehab talked a little bit about earlier, but just kind of repeating and bringing that back again. So again, the purpose of this study, it was to perform a meta-analysis, and it was going to compare single versus double bundle ACL reconstruction, and more particularly the outcomes and how these patients do. So what they did is they primarily analyzed outcomes from level 1 randomized control trials, and then they also secondarily analyzed outcomes from level 1 to level 3 studies. And they searched a couple of different medical databases. They searched Medline database, they searched MBase database, and they also hand searched journals, which they wrote in their paper. I thought that was pretty cool. You don't see a lot of people hand searching journals these days. And the terms that they look for were ACL, anterior cruciate ligament, as well as double bundle. And they included the study, they included the level of evidence, the number of patients, the patient demographics, the type of surgical intervention, the amount of time for follow-up, and the preoperative and postoperative evaluation results. And they excluded any studies that were level 4 or level 5. So in results, they ended up getting 9. They ended up looking at and analyzing 9 studies, which included about 4 randomized control trials. And if you're watching this on YouTube, you can see the charts of the tables, one on the left side and one on the right side. But these are just looking at some of the outcomes. This is looking at the KT 1000 arthrotometer results. And basically what it showed is that the KT 1000 side-to-side differences. So they measure it on the operated limb and then the contralateral non-operative limb. And they found that the side-to-side differences were closer to normal in patients that were treated with a double bundle ACL reconstruction and those that were treated with a single bundle ACL reconstruction. And they found this to be statistically significant at a 95% confidence interval with a p-value of less than 0.05. And then they also looked at the pivot shift results. And again, these two are talking about the level 1 evidence studies that they analyzed. And what they noted from the pivot and shift is that the ACL, the patients that had the double bundle ACL reconstructions had a higher, odds ratio or positive log odds ratio of having a normal or nearly normal pivot shift test versus the single bundle ACL reconstruction. But these results were not statistically significant like the results with the KT 1000 arthrotometer was. So in conclusion, they noted that there's actually no clinically significant difference, although we did just mention that the KT 1000 was statistically significant, but it wasn't clinically significant between single bundle and double bundle. There were no statistical significant differences in regards with the pivot and shift test postoperatively in single bundle versus double bundle as well. And some of the limitations for this is the reporting and the performance bias. And one of the future things that they noted in this paper, the future considerations were kind of adhering to consort or use of standardized outcome measure, because some of these different studies reported different outcome measures. Some studies did the KOOS questionnaire. Some studies had the Lysholm questionnaires, but they were able to get, all the studies had the KT 1000 as well as the pivot and shift test. So agreeing on kind of the standardized outcomes on how to measure outcomes after ACL reconstructions would lead to better quality studies. So that was one of the kind of future things that they noted from this study. And again, this is just showing that there's really no difference in regards to single bundle versus double bundle when you look at the clinical outcomes, which is being one of the things that highly talked about a little bit earlier on in ACL reconstruction. And so this is just another one of those papers that show there's not much difference. And again, like Ehab mentioned a little bit earlier, with a double bundle, it is a little bit more technical than a single bundle reconstruction, and it does have some increased operative time.
Yeah, this is a big paper, level 1, or it reviewed the level 1 studies. But kind of piggybacking on that, you have this paper too, kind of comparing, talking about the anterior or single bundle versus the double bundle. We were talking earlier how we three of us residents haven't seen it in our training so far, and if clinically there's no significant difference to doing it. I've never seen the KT 1000 device used. I don't know about you guys, but if that's the only significant difference between the two, I don't I can understand why the posterior the double bundle technique is not really being utilized.
Yeah, I haven't seen the actual, I haven't seen it in actual use, with my own eyes. I've seen the machines, at least stuff from pictures, because when I was reading these articles, I was like, I have no idea what a KT1000 arthrometer machine is. So I had to, Google and see what it was, but I've never actually seen one in real life being used. I'm sure that gets used. It has to, but I've never seen it.
All right, let's keep going. So next paper is mine. So this is a big study. This is a 10-year comparison of ACL reconstructions comparing the hamstring tendon and patellar tendon autograft. So this is a big 10-year prospective trial. So a little bit of background information regarding the two types of grafts. Bone patellar tendon bone autograft has, in the orthopedic world, been considered the gold standard. It utilizes bone plugs to incorporate into your tibial and femoral tunnels. There have been studies showing that there's faster uptake time compared to a purely tendinous graft. But there is, some cons with this procedure. You have the increased risk of anterior knee pain and patella fracture since you're taking, large portion of your patella bone. And there's also the hamstring autograft. Typically, we harvest the semi-T and the gracilis autograft, and it's called a quadruple the hamstring, because you take these two grafts and double it. So you have kind of four. It does biomechanically, it's shown that it has a higher load to failure compared to the gold standard of the bone patellar tendon bone. There's less morbidity due to a smaller incision and less anterior knee pain. But there has been, some discussion in the literature about, hamstring weakness, since you're harvesting, two of your hamstring tendons. So the purpose of this study is a big prospective cohort study to assess and compare the long-term outcomes comparing these two types of grafts. So they took 180 ACL deficient knees, split them right down the middle. 90 of them underwent hamstring tendon reconstruction, and 90 did the bone patellar tendon bone. All these surgeries were actually performed by one surgeon, which is pretty interesting. And from that point on, all the procedures were observed prospectively for 10 years. They took subjective, objective, and radiographic data at multiple intervals at 2, 5, 7, and 10 years. They took multiple subjective measurements, and that included the International Knee Score, symptoms related with a certain activity, the Lyschel Knee Score activity level, postoperatively, harvest site symptoms, and kneeling pain. And objectively, they looked at the clinical evaluation of the ligament reconstruction, the knee range of motion, single leg hop, and then radiographic assessment. So lots of variables here that were taken into account. So just talking about the statistically significant results, there was a higher incidence of radiographic evidence of arthritic changes in the patellar tendon reconstructed knees. And as we kind of already, as I mentioned earlier, kneeling pain is a con of these patellar tendon grafts, and the study showed that kneeling pain significantly increased in these specific patients. Although it wasn't statistically significant, there was a downward trend in the IKDC and the patellar tendon group compared to the hamstring group. And they also had the study kind of came up with this ideal outcome, quote unquote, which included this International Knee Documentation Committee score or grade A or B, and then a radiographic grade of A. And it actually showed that this hamstring tendon group, 69% actually met this ideal outcome compared to the 47% of the bone patellar tendon bone patients. So in conclusion, clinically, both these hamstring and patellar tendon autograft reconstructions have excellent long-term outcomes, subjectively and objectively. The hamstring tendon autograft showed more favorable outcomes, albeit not necessarily statistically significant, but it did show more favorable outcomes compared to its patellar tendon counterpart. There were a few limitations to this study, though, albeit there was only one surgeon that performed all 180 of these surgeries. It was noted in the paper that this surgeon was more of a bone patellar tendon bone veteran when the study started compared to the amount of procedures he had done previously, including the hamstring tendon. So you have to take that into account. He's done more patellar tendon surgeries as compared to the hamstring tendon, but still the study showed that the hamstring tendon did more favorable. So
yeah, I actually had one of these done. I had my patellar. I got patellar bone done, and I had a little kneeling pain for a little while. Now I don't. But no, I mean, I think those are all, important things, and definitely you need to even know some of that to be able to counsel patients and let them know, like, these are, there are more than two different graft choices. These are a couple different graft choices. These are pros and cons to each of them. They all tend to do very well, especially a study out that shows after 10 years, they both do well as far as outcomes are concerned. But, these are some of the things that you can help counseling them on when you're in the office, and you all are trying to figure out what the, what's the kind of graft choice you want to go with.
Yeah. And, I wish they kind of, in the study, since it was such a long-term study, I wish they kind of looked at time to return to activity, because, there is a discussion about this, bone patellar tendon bone having quicker bony uptake compared to other grafts, and it kind of can potentially lead to earlier return, but everyone's different.
That's true.
So I'm not sure.
We're all not Adrian Peterson. He had an ACL.
Yeah, exactly. Well, I think he's the he's the outlier.
Yeah, for sure.
Was it like 6 months or something like that?
Yeah, it was. He's a beast. He's not the normal human.
Yeah. All right, and so we got one more paper. And so this is just a big randomized trial of treatment for ACL ligament tears.
Yeah, thanks for inviting me. Glad to be here. So this is Frobel's study taken in Lund University at the Clinical Orthopedic Institute in Sweden. This is a randomized trial just about treating acute ACL tears. So the reason they sort of started doing this trial was because they noted that pretty much all acutely torn ACLs were commonly treated surgically, but there wasn't really any high quality randomized control trials that actually compared ACL reconstruction with other treatment options, especially non-operative options. So they wanted to investigate you can keep going. They wanted to investigate structured rehab with early reconstructive surgical option versus the structured rehab with the optional delayed reconstructive surgery. And so they screened any patients 18 to 35 years of age that presented to the ED with a knee trauma, and it had to be any rotational trauma within the last 4 weeks on a knee that was previously uninjured. Additionally, they had to find ACL insufficiency on their clinical exam, and these patients also had to have a score of 5 to 9 on the Tegner activity scale prior to their injury. Tegner activity scale, just for reference, basically denotes how active you are. A 5 is someone that plays in non-professional sports recreationally. A 9 is someone that competes in non-professional sports. And so they also excluded anyone that had a total collateral ligament rupture or full thickness cartilaginous or meniscal lesion on MRI. They then randomized all their subjects to different surgical timeline groups, and they followed this rehab protocol that they performed at their institution that was consistent with ACL literature for rehab. In the instance that meniscal surgery was needed, they performed it during the ACL reconstruction, but any patients that had meniscocapsular separations that were greater than 10 millimeters were excluded from the study just because their rehab regimen had to change from there on out. So continuing the methodology, Early ACL reconstruction meant that these surgeries occurred within 10 weeks by one of 4 knee surgeons, and whether or not they chose the patellar tendon or hamstring tendon reconstruction, as Tucker previously just talked about, was really determined by their preference. The patients that were randomized into optional delayed reconstruction underwent the same procedures only if they desired it and continued to have these symptomatic knee instability, an ACL insufficiency, and a positive pivot shift test at that point. I think it turned out to be an average of about 11.6 months for the delayed reconstruction group if they desired to have surgery. This group talked about primary outcomes being the average score of knee injury and osteoarthritis outcome scores from their baseline to 2 years, excluding the activities of daily living subscale. They also looked at other secondary outcomes, including the activities of daily living, as well as the SF-36, which is a quality of life measurement, Tegner activity scale, and others. They also looked at more exploratory outcomes or clinical outcomes like knee stability, pivot shift test, and the KT1000 that Wendell Cole talked about previously as well. So their results, they had about 62 subjects that underwent early ACL reconstruction and 59 that were randomized into the delayed optional reconstruction. Of those 59, less than half of them ended up undergoing reconstruction. And you can see from these graphs, the mean primary outcome, the knee injury and osteoarthritis outcome scores were insignificantly different. They changed from 39.2, they changed 39.2 from their baseline to 2 years in the delayed group and 39.4 in the early group, which was an absolute difference of 0.18 with significant data showing a confidence interval of 95%, p-value p-value of 0.96, meaning there was an insignificant difference between the two groups. You can also see on the post hoc as treated analysis, they separated out the delayed reconstruction versus just rehab alone groups and demonstrated that there was no difference or no significant difference between those groups either. So in conclusion, there's no better patient outcomes with the structured rehab and early ACL option versus optional delayed reconstruction. And however, like this paper was really limited by how specific their rehab protocol was. They didn't discuss it too thoroughly in the paper itself, but it was something that was specific to their institution, that was consistent with rehab literature. And then on top of that, their patient demographic was focused on, people from 18 to 35. Anyone older and anyone younger couldn't really be adequately derived information from this study, whether or not they should have the ACL reconstruction. And then on top of that, they focused on patients that were really active, anyone that was participating in sports, either at a non-professional level or just recreationally. But their takeaway was that greater than half of ACL reconstructions could be avoided without adversely affecting outcomes. They reported that about greater than 200,000 ACL reconstructions happen annually in the US, which ended up costing about $3 billion. So theoretically, their thoughts on the matter are about saving $1.5 billion, which is pretty significant. But if you consider which patient demographics this has to be in, it definitely goes less than $1.5 billion that you're saving. And for future studies, replicating the study at other institutions with different rehab protocols or different patient populations are necessary to really generalize the results of this study.
Yeah, I think it's good to know, not every patient needs an ACL reconstructed just because you tore it. There's a lot more that goes into it. You can talk with them about their goals, their activity levels, because there are a lot of people walking around without an ACL, but, they don't require cutting and, doing anything of that sort. You can go up and down stairs and walk around and get a functional limb without an ACL, actually. But I think it's always good to know, kind of what the patient goals are. And I mean, I think this is a good paper to kind of talk about, early versus delayed surgery. But yeah, I think you did a good job summarizing this paper.
Yeah, I think this is interesting because I recently had someone in our intern clinic who was, an older person who had a non-sport involved, traumatic injury resulting in an ACL tear. And, as of right now, they're in therapy and we're, treating this non-operatively. And, like Wendell said, it kind of goes into like your patient demographic. But, it can be hard from a clinical standpoint to tell these patients, like, yes, you tore your ACL, but based off of your, age, lifestyle, level of activity, et cetera, you don't necessarily need surgery. And I think there's this mindset that, I have this ACL tear, it has to be operated on. And you're actually kind of like talking people out of surgery, which is, not very common in our line of work.
Right. Yeah, totally true. I remember I think I tore mine and I had a delayed reconstruction maybe 2 or 3 months later. But, in the meantime, like I was like still hiking, like I had traveled to another country and was like hiking up mountains and stuff, like, so you can get around. You may not be as, mindful, you need to be a little more careful, but it can work. I think it's, again, we're just here to help the patients out and get them to their desired activity level. So if their activity level desired is to go back playing D1 football and go pro, and, they want to be a running back, they're going to need their need to cut and, do these different things versus if it's, Bill, who just happens to play like flag football on a random Saturday and all the other days of the week he's not really that active, and he just happened to go out one day and tear it. He may not necessarily need it. That may not be one of his goals. But yeah, I just think it's just worth, again, just talking to the patients and seeing what they want to do.
Mm-hmm. Right. All right. Well, that concludes our discussion on our ACL reconstructions, our first for this Sports Citation Classic. So hopefully you guys listening learned something in regards to ACL reconstruction and realized that there's a lot of research done on this. So I hope you guys enjoyed it.
Oh yeah, we'll see what's in store for the next one.
Looking forward to it.
Thank you so much. Really appreciate it. Really appreciate your guys' time. Hopefully everyone that's listening enjoyed as well.